Thank you so much, and it's absolutely wonderful to be here. Before I start, I would just like to acknowledge the traditional owners and the custodianship of the lands on which we meet today, and pay my respects to our ancestors, their descendants, who continue cultural and spiritual connections to this country. We recognise their valuable contributions to Australian and global society. So I'm actually very excited to be here talking to you because I think probably am representing a new science for the Academy and also for the University of Queensland. So the University of Queensland has decided that digital health is a strategic priority for the university for a number of reasons. Firstly, the industry globally is looking to tip about $1 trillion in the next couple of years. The benefits of digital health have been proposed to be on par with the introduction of antibiotics. Up until now, we haven't actually had a dedicated stream of science to investigate this, to examine that statement with rigour and to advance Australia towards being a global leader in digital health. As I came up, I asked Isaac what he wanted me to say, and he said, talk about the challenges of being a clinician scientist. And Isaac, I'm sorry, all I can think of is that it's fabulous. So I work as an endocrinologist at the Royal Brisbane and Women's Hospital, and I'm very privileged to serve that diverse community. But I also run a team of about 30 researchers. I'm currently executing about $6 million worth of grants. And so really run that, I guess, bridge between the two. And initially I thought I was bad at both. But actually what I realized is that one makes me better at the other. So it is a fabulous life. It is rich, it is creative, it is satisfying, and I couldn't recommend anything more strongly to do with your time on this planet. So I'm going to start off by asking, if you're wearing a smartwatch, put your hand up. Okay, quite a few. Keep your hand up if you know you're in the middle of an industrial revolution. So David's the only one who's participating. And the global literature is now suggesting to us that we are actually in the middle of the fourth industrial revolution. The first one was the introduction of steam trains, which allowed us for the very first time to move outside the villages that we were born in. The second industrial revolution was the introduction of electricity, where for the first time, reading and writing and education could be democratized as families who are not particularly wealthy could study when the sun went down. The third industrial revolution was brought about by the introduction of computers. And many of us can remember, well, I can, my very first computer bought by the nuns. And we were able for the very first time to communicate via email, to store enormous amounts of information on our little desktop and start to code. The fourth industrial revolution is driven by digital information. And what it's doing is it's allowing us to connect with each other around the world and on different planets in real time. It's forcing us to think in real time, not in retrospective, and forcing us not necessarily to change what we do, but how we do it. And I'm starting with a picture of an astronomer. This is Galileo, who discovered the very first planets in 1609. There wasn't a whole lot of progress, partly because people didn't believe planets existed or that they weren't important. Some other astronomers came along, except they weren't astronomers. They were physicists, mathematicians, geologists, and chemists. And they all worked independently in their discipline on this thing called planets because there was no planetology. Planetology wasn't a thing. They refused to teach each other. They worked at cross purposes. And our progress, particularly in discovering exoplanets, was halted probably for centuries because of the lack of a single discipline or single science focused upon this new thing, planets. That was until some universities got together and said, hey, planets are a thing, we need to invent a new science and a new discipline. And this is called the One Sky approach. And I'd really recommend this book that talks about what happens when new elements or new streams of science are developed, and the fact that those new streams struggle. People don't necessarily know how to study them. They don't know what to do with it. There's siloed effort going on. But once society recognises that this is a new thing and applies it, so remember, for a long time it was theoretical. Let's see if there's a planet. Let's see what's on it. Once NASA and later ESA, and of course our colleagues in the USSR and China started to apply it, things really started to accelerate. And look at how our discovery of exoplanets is progressing now. Watch that scale on the left. So now there is such a thing called a planet scientist who is an expert in geology, physics, chemistry, maths, and engineering. And the ability for our society to discover exoplanets is occurring in an incredibly rapid way. And of course, my proposal is that digital health is the new planet. So at the moment, we don't have a discipline devoted to digital health. It's a new science. We have fragmented effort occurring in different disciplines without a united language, a united ability to move it forward, and without a united focus on our consumer. So at UQ, we're really addressing that. We've set up the University of Queensland Digital Health Research Network that includes people from medicine, nursing, allied health, maths, science, physics, IT, electrical engineering, business, economics, law, history, and anthropology. So a really broad group of people, all focused on this new issue, which is obviously part of our society and will become even more prevalent. We've agreed on a definition, the application of information and communication technologies in order to improve healthcare and health outcomes. Let's go back in time again. So this is the Royal Brisbane, buying cigarettes at the bedside. It was probably the respiratory ward, David. And the reason I put this up here is because in the 1950s, we had a very different way of thinking. You would only come up to the hospital for your acute illness, probably a broken leg or acute pneumonia, and then you'd go home again. You paid for that single episode, or someone paid the hospital for that single episode of sickness. In fact, hospitals were rewarded for treating sick people. They were not rewarded for keeping people well. The patient data was just seen as a byproduct of the interaction between the clinician and the consumer, because usually it was a single highly specialist doctor who wrote notes to prompt himself, sorry, it was always himself back then, to remember what the actual interaction was. That information was not meant to be reused for quality improvement or research. And in fact, there was almost no reporting, except for the activity being counted by the finance team. And research was done very separately in an ivory tower university that perhaps published papers but wasn't really part of the healthcare team. We can't keep going like that. And we're already seeing fabulous people like Alan who are forming those new teams. But our burden of disease is no longer fractured legs or acute pneumonias. It's people who have 6 or 7 different things wrong with them. This person doesn't necessarily need to come to hospital for all of that. In fact, we need to keep them out of hospital. And this is a complex adaptive system. So we can't reduce the effect of a drug on somebody who not only has diabetes, but also has cancer, schizophrenia, a degenerative neurological disease perhaps, and perhaps an acute infection. So our ability to do single clean interventions on control groups is increasingly becoming muddied because of the complexity of chronic diseases that our population now carries. So it's difficult in a complex adaptive system to apply traditional scientific methods. So I think that we're seeing an update. We're seeing that we are now collecting rich clinical data on every patient every time, and clinical informaticians, and I'm one, use that data to actually look at real-time interventions in health where research meets practice. And that's why I think it's interesting for you as a group. Clinical informatics is the clinical arm of digital health. That's what I am. And that's the clinical application of informatics to deliver healthcare services. And notice it's very much about deliver. And we're not here because we're interested in tech. We are not app coders. What we're interested in is improving care. And there's some principles around how we're starting to redesign the healthcare system. The data is centred around a consumer, not around a disease. So single disease registries are incredibly important for basic science type approaches, but they struggle in a complex adaptive system. So we are starting to see the centering of data around a consumer who may have the data from her cancer, from her dementia, from her illnesses, all collected in a single space with her at the centre and not a particular hospital. The data is collected for every patient, every time, in real time, and the data is available in dynamic form to the healthcare providers, to the researchers, and to the system. So data for traditional research has evolved since that 1950s style of researching. It is clinical forms usually collected to answer specifically a single question. The data elements are centred around the study. So I've obviously done this, a diabetes study. We ask them a whole lot of questions about their diabetes and then maybe 6 questions about what other conditions do you have. And I worry that when we do that, we're missing comorbidities or that the consumer has recall bias. She might forget that she had breast cancer in 1998 that was successfully treated. The system we're setting up in digital health is actually to tackle complex modern problems and to start to introduce complexity thinking to the adaptive system we're working in. The data that we are going to use will be fresh. We now have the ability to tap into data which is 15 minutes old across millions of episodes a month. We're trying to provide a complete picture of the consumer so that we're not relying on recall, we're not relying on reporting, but we actually have a real-time record of every time the consumer touches the system. This provides us a complete picture of the population. We are no longer subject to sample bias because it's every patient every time when they touch the system. And the data is used for clinical care is the same data used for research. This does introduce some data quality issues, and David and I were just speaking about this, because sometimes doctors don't code properly. Sometimes they should put in the fact that this person has diabetes and they just don't. So I'm not going to talk about my research today in the interest of time, but one of my grants is actually looking at automated phenotyping of consumers using their electronic record data. So for example, if somebody we know can see from the record is attending dialysis, they go to the renal outpatients and their creatinine is over 400, I'm pretty sure that they've got renal failure, even if it's not coded. And we're starting to use some sophisticated AI techniques to actually automate that phenotyping to create robust and reproducible phenotypes that could be pulled out for a cohort which Alan or David needed to look at. And this is the Sullivan hierarchy of data needs. I've shamelessly adopted it from Maslow. You'll see down the bottom, the general population, well people off free living in the society have very little data. So the data amount, integrity, granularity, and freshness goes up as you go up the pyramid. So if you're free living out in the city, we're not going to have much data on you right now. If you're at the very top of the pyramid, you're ventilated in ICU at the Royal Brisbane, completely consumed with lines. I am going to know every breath and every mil of urine. So the amount of data that I have when you're that ill and that embedded in the system is incredible. It allows me not only to do descriptive analytics to say, well, this is what the blood sugar is right now, but to start to look at predictive analytics. I predict that this person's going to have a hypoglycemic event tomorrow, and even more cleverly, to prescribe prescriptive analytics. So I can see that this person's going to have a hypoglycemic and you need to reduce their Lantus by 3 to avoid it. So because we've only got the data at the very top of that pyramid at the moment, that's all we can do it on. But I'm seeing a time, and that's why I ask everyone who's wearing an Apple Watch, where perhaps we'll be doing prediction precisely in the community and not just treatment. And that's the idea of precision prevention, which we're starting to explore. So all of those precision medicine approaches work in that pyramid. We're just missing data at the bottom, which means that that's at the moment immature. But certainly at the top of that pyramid, we have active grants doing that right now. So digital health is full of buzzwords and glossy brochures with, transformation, artificial intelligence, and all the rest of it. There's a lot of doctors who think they're going to code an app and become a billionaire. And I don't want to at all discourage anybody from that. But what I would suggest is that 5 years ago in health, it was a digitally naive environment. So if you made an app, it would almost certainly be adopted into the workflow because there was no digital workflow. Over the last 5 years, we've seen rapid digitisation of healthcare to the point where, as of last week, all public healthcare in Queensland, 70% of all of it is delivered via a single instance of an EMR. That goes for everything from the individual blood sugars, each blood pressure, each oxygen saturation, each lab result. So to introduce another application into that complex digital environment is obviously fraught with danger. So I guess that's why clinical informatics and this sort of idea, I guess, is going to be important as we continue to innovate. So we suggest you start to approach digital transformation in a really measured way. So Horizon 1 is all about digital workflows. That is understanding how is healthcare delivered, what data is entered, how is it efficient, and are the consumers and the staff having a good experience with the digital collection. Once you have that secure, you then move on to Horizon 2, which is pulling the data out of those digital workflows and analysing it. You can't start with the data, you have to start with the workflow. And then once you're looking at that data, you shift through descriptive analytics, predictive analytics, and prescriptive analytics. And the third horizon is where everybody wants to play, and that's where in all the glossy brochures, that's when you take your digital workflows, your data analytics, and you innovate. And that's where we can start to do some really cool stuff. Like, for example, we're at the moment delivering a code which allows us in Queensland to monitor in real time everybody that's eligible for a clinical trial with 15-minute refreshers, which is so incredible when you think about the number of people that go through charts or clinics trying to find people. So that Horizon 3 is where everyone wants to play. It's hard given how complex it is now, but that's where the fun is. It is so fun. So in the interest of time, I'm not going to spend too much more on this, except to say when you're thinking about research now, think about, is the environment I'm going to do some work in a traditional environment? So low digital maturity. This is usually private hospitals, perhaps some GP surgeries. NGOs haven't digitised very much yet. In that setting, you can define a sample size by size and time. You can actually collect all your data and then do an analysis. You can do a pre-post, an RCT, and you can collect your data independently. Design your own really cool app or spreadsheet, which allows you to do a bespoke data collection. And you can consent the patients at the same time. If you're heading into a digital health or heavily digitised healthcare facility, you need to rethink the way you design your trial, because your data is actually being collected on every patient every time. So your sample size is almost irrelevant if you're capturing every patient every time. The data is dynamic, it's real time. It allows adaptive trial easily. Adaptive trials are things like looking back through the record, we call look back, and see, okay, if we had similar groups of patients who are either on enalapril or ramipril, which group did better? That doesn't necessarily mean anyone needs to be randomised. We don't need to design a trial, and we can get some really cool results out of enormous sample sizes really, really quickly. The extraction of data from the systems does cost, and people are often happy to cost up a research nurse, but not quite so comfortable costing up data extraction. So just to keep in mind, and dynamic consent is something we're still working on. So I'm going to stop. I did love the close back in the 50s. And challenge you to start thinking about healthcare as a learning environment. So instead of research papers being your endpoint, in a digital health environment, every piece of data that's collected is potentially reusable for learning, and your findings are easily translated back into the clinical workflows via decision support, or what we call power plans or digital guidelines, to actually change practice quickly. It takes us about 3 hours to change the guidance for the treatment of a specific disease in Queensland for 70% of all healthcare. This is a diagram to illustrate that learning healthcare system again, but at the centre is the consumer. It's not my research collection, it's the consumer and all the data that she brings with her. It's critical that we maintain academic rigour, that we continue to publish, and that we continue to set our benchmarks or our goals for the learning healthcare system via published evidence. So I'm going to stop. So clinician researchers, research meets practice at digital health. We still absolutely need traditional research, and it's incredibly effective. But our consumers often now have 3 or 4 diseases, and we're starting to need complexity thinking to cope with it all. Digital is where quality improvement and research meet together, and these digital platforms enable this congruence. And I'm going to finish by showing you what the planetologists did last week. I don't know if you've heard this, but it's very cool. Sorry, we don't need Ranger Sammy. Oh, we're not going to show it, but it was the first sounds from Mars. I'll kick it again. Okay. So from having nobody that studied planets to this. It's all right. The irony, I'll send the link around. But I guess it's a challenge to you all to think about a new way of approaching science now that we have this digital rich environment with enormous amounts of data collection. And I guess to think about digital health as one of the new streams of science, tackling a wicked problem and a very cool place for clinician scientists to work. Thanks.
Do we have any questions from either?
So you mentioned, you touched on a couple of times the word ethics in your talk, and with the massive volume of data that's coming through that's being extracted from patients, I'm just curious how that's going to evolve, especially when over the last few years and decades, ethics has more or less started to narrow into the point where you're only allowed to use the data you collect for what you state, the single event you're going to use it for. So when you have all this data coming in, which you want to use for multiple different purposes, how do you actually manage that?
So you write your ethics application very carefully. So if you're writing your ethics application as in I want a data set, that's what you'll get. If you write your ethics application as in I'm going to contribute to a learning healthcare system, that's a very different proposition for the HREC. So I would suggest that if you are looking at analysing real-time data sets or planning to engineer decision support back in, that you be upfront and clear with your HREC about what you want to do so that they understand this. They've been absolutely fantastic. There's an HREC group of practice that have been talking about how to deal with this issue. They absolutely understand that this is a new paradigm for science and for ethics, and they've been incredibly supportive, Isaac. It's all about just being honest and upfront about what you're wanting to do, making sure that you remain within the legislative boundaries and also the social license. So sometimes something might be legal, it might be ethical, but it doesn't pass the pub test. And so I always think about those three layers whenever I'm trying to make a decision about research design, because just because it's ethical, just because it's legal, doesn't necessarily mean I should do it if it creates antibodies in people. So you have to just be, I guess, innovative. Don't add it on as an afterthought is what I'm trying to say. Your whole thinking around how you're going to analyse your data set needs to incorporate that from the get-go. Yeah.
It's more a question about like in practice. So I know that at the moment we're struggling in the hospital to get details about patients and their conditions from their GPs. Oh, yeah. How are we gonna like get, because that would be awesome if we could just have that stream flow, but it's currently not working.
Yeah, so two things. At the moment, Queensland has a real national advantage with our single instance of an IMR. So if you go to Victoria, for example, there's 3 or 4 instances. They're having to harmonise that data and then integrate it with the PHNs. It's a nightmare. So we've already harmonised our acute data set. We're working with Health and Wellbeing Queensland to try to harmonise that wellbeing data set as well. We do have a health information exchange in Queensland called the Viewer, which I'm not sure if you're familiar with, but it does allow an upload of data into the engine that allows the primary practitioners to see what's going on. Now, my proposal is we should make that two-way. So we've got an MRFF proposal up at the moment looking at standards-based integration of primary care. And we're going to use something called FHIR, a Fast Health Interoperability Resource, which is an API that allows harmonisation of various different elements. So the API calls to the primary care practice and brings it in, and likewise. So the advent of, I guess, standards is going to be really important because software vendors have really just been focused on that horizon one, just individual episodes of patient care, instead of thinking about, well, this element is part of a learning healthcare system, how do we enable that? So we're really pushing that type of thinking. So I'm confident it'll come. The interoperability resources are getting better and better, but we shouldn't wait for perfection. So a lot of people in digital health are waiting for everything to be integrated, everything to be interoperable. It's never going to be. So start with what data sets you have, play to your strengths. And as the government and the scientific community see the value, there'll be ongoing investment. So don't wait for perfection. Whatever data set you have, analyse that within the limits of its efficacy.
Thanks, Claire. Great talk. You mentioned that we're in the middle of the fourth, or starting the fourth revolution. Is our medical workforce ready for this revolution? And
that's such a Dorothy Dixer. Thank you. No, it's not. Great question. It's not. So I'm very pleased to report on two efforts. So University of Queensland is putting together a graduate certificate in digital health, which I got half funded by the Digital Health CRC, and that's starting in February. So really excited about that. We've got $500,000 worth of funding from the Digital Health CRC to really set us up to do that. We're also going to micro-credential that and badge it so that we can put out snack-sized, pieces of information for our medical workforce. I'm also sitting on the AMC National Review of Digital Health in the Medical Curriculum. And the AMC has acknowledged that this is a problem and that we're still training people, in traditional ways, I guess. So the AMC is onto it. We've got another board meeting on Monday. So I think expect to see something out of the AMC. So that's the Australian Medical Council, for those of you who may not know, that sets the standards for medical education in the next 6 months.